Good evening, everybody, and welcome to the ISO webinar series 9. This tonight we will focus on pancreatic cancers, and to lead this, we have a star-studded debate initially on are vascular resections justified in locally advanced pancreatic cancers. And of course, we had a lot of discussion in various scientific academic groups as well about this. The larger issue to be debated was whether arterial resections were sort of, uh, the need of the hour, or whether we need to go ahead with that. So I think, but I would leave it to the debaters. Dr. Manish Bhandari and Dr. Ramesh would follow for and against respectively, and subsequently we'll have a star-studded panel again on borderline resectable pancreatic cancers. So I'm sure that this is going to be a very exciting webinar, and we would sort of, first start with Dr. Manish, who would go for, subsequently Dr. Ramesh against, and none other than Professor Shailesh Shikande to give his expert comments. Manish, over to you, and we are all waiting to hear from you, all of you.
Thank you, and very good evening. First of all, thank you for this opportunity. It is slightly tough, as everybody told me, that you are debating against none other than Professor H. Ramesh, so it is not going to be easy. I'm going to share my slides. Just let me know if the slides are seen.
Yes, Manish.
It is visible, sir. Good to go.
Yeah.
All right. So in the next 8 to 10 minutes, I'm going to speak on vascular dissections. Are they justified in locally advanced pancreatic cancer? To begin with, I just had this poll conducted today morning on the ISO and the TMH Surgical Alumni Group in preparation for this debate. And the answers that I've got is yes in 67% and 33% have voted against. There are few quotes, and I've tried to address some of the responses that have been raised. As Dr. Arvind also mentioned rightly, that whether it should be only arterial or it should be arterial venous combined, that is something that also we need to see. Apart from the real standing of vascular resections in LAPC. So let me start strong by stating that it's an aggressive cancer. We all know that pancreatic cancer is aggressive. And when you have a disease which is aggressive, the treatment also needs to be aggressive. We cannot be milder with the treatment, and hence the radical resection is the way forward for all pancreatic cancers that we know. We also know so far that what works in PDACs is a complete or an R0 resection. That's the only thing which had shown to improve survival. And of late, with the improvements in chemotherapy, addition of chemotherapy or completion of the therapy along with an R0 resection are the two most important factors which give us long-term outcomes in PDACs. And in order to get these R0 resections, we have the surgical tools or techniques which have got evolved over a period of time over the last 2-3 decades. These things have got refined. We have the artery first approaches. We have the triangle clearances for the so-called resectable diseases, the anatomical resectable diseases. When we have borderline resectable or locally advanced diseases, often because of involvement of the vein or artery or combined vein and artery, we need to perform vascular resections and the newer technique, which is arterial divestment, which is a substitute to arterial resection. Now, LAPC as a definition, I'm sure everybody is aware, but I would just touch upon this. Basically, LAPC means more than 180 degrees of involvement of superior mesenteric artery or common hepatic artery or celiac axis for pancreatic head uncinate tumors. For pancreatic body tumors, when it is aortic involvement or gastroduodenal artery involvement, that becomes locally advanced pancreatic cancer. But this is a broader classification, older classification. You see here that there are 4 different ones. The commonly followed one is the NCCN one. But recently, we know that there are more and more classifications which are getting devised even within locally advanced, because this is a broad spectrum. It's not correct to group all of these tumors into one. and then say that locally advanced is synonymous to unresectable. So we have the stages defined, whether it's celiac axis alone, whether it's celiac axis along with common hepatic artery, whether it's combined celiac axis and SMA, whether the vein involvement is the reason for unresectability, unreconstructible vein is the reason for for LAPC, for defining it as LAPC, and when there is complex vascular involvement which puts together all of these different involvements, which is the last spectrum of LAPC. So this is the reason why this is happening is because there is more and more interest to do and perform these resections, radical resections in locally advanced disease. Going forward, of course, we all must remember that biology is the king. There is no denying of that fact. But this is a famous quote which everybody knows, but this stands true in 1990s maybe, and even partly it holds true today as well. But what is not appropriate is that biology is equal to a vascular involvement in pancreatic cancer, and this is what we all must understand. The local vascular involvement is purely anatomical reason, and we know that the biological behavior of tumors, even with involvement of the vessels, can be different. They can be similar to resectable disease in certain scenarios, and it can be worse the other way around as well. Hence, we know that these locally advanced diseases, many a times they remain localized. And the reason could be a better biology as well, that even with a tumor with vascular involvement, they still remain localized. And hence, whenever we have the biological, favorable, permissible scenario, the anatomy should not dictate whether a patient should undergo resection or not undergo resection, and thereby refuting the chances of survival. The other thing which is changing in pancreatic cancer is chemotherapy. The FOLFIRINOX and the GEM nab-paclitaxel is definitely promising. Of course, it is not perfect. We need to have better chemotherapies even beyond FOLFIRINOX and GEM nab-pacli. But what we know today is that they are far better than what we had before, which was essentially gemcitabine alone. And the concepts have changed from adjuvant chemotherapy to neoadjuvant therapy, and more recently to total neoadjuvant therapy when it comes to locally advanced pancreatic cancers. And the decisions to operate or offer surgical resections are no longer purely based on anatomy, but it depends on the response to chemotherapy. It depends on the ability of a patient to recover from the major surgery that is determined by clinical parameters, and the technical factors, which is reconstructability, that is whether we can do a safe resection and reconstruction of the vasculature. Now, I'm not going to discuss anything about vein resections because that is more or less agreed. I'm sure Ramesh sir would also agree that. So we will not go into the details. There is a spectrum of vein resections as well. The ISGPS classification 1, 2, 3, 4. The type 1, 2, 3, 4 are definitely feasible and should be performed in whenever there is technical possibility to do it. Perhaps the only contraindication which stands today from vein point of view is when you have extensive collateralization and a portal cavernoma formation where there is technical impossibility to do any safe venous resection and reconstruction. Apart from that, any other type of a vein involvement is considered resectable, provided it is biologically permissible and conditionally permissible. Just one thing, recent publication that we all have, this is Indian data. Ramesh sir is also part of it. 11 Indian multi-center institutions collaborated, and portal vein resection outcomes you see in Indian scenario is 25 months. And the most important factor, if you notice here, is the treatment completion rate and the R0 resection rate. These are the only two factors which determine long-term outcomes, and not the type or the extent of resections in these patients. Again, highlighting that complete resection and treatment completion are the most important factors which drive long-term outcomes. Now, coming quickly to different scenarios in locally advanced disease. Again, I would say here that body tumors, tail tumors, celiac axis involvement, this is only recently that the definition has got changed. Otherwise, the celiac axis involvements used to be grouped as LAPCs only. But now the classification is that if the gastroduodenal artery is free, if only celiac root is involved, whereby a modified Appleby procedure is feasible without any reconstruction, that type of a tumor has now been classified as borderline resectable as per the NCCN. But you have different types of celiac involvements also. And this is again a very important classification devised by the Mayo Clinic group, wherein the different extent of celiac involvements, whether a gastroduodenal route is involved, whether it's free, whether there is combined involvement of the SMA, and along with that, whether there is left gastric involvement, whether portal vein is involved. All of these factors put together, they define the class of the celiac involvement, and depending on the class of involvement, the extent of resection planned in these patients is also going to be different. And there is usually nowadays there is no debate in class 1 or class 2 tumors. They do go for surgery. There is still doubt on whether class 3 tumors, when there is a combined vascular involvement, they should be offered surgery or not. But probably yes, you have biologically permissible scenario. The most evidence for long-term outcomes is also for celiac axis resections, which is arterial resections for distal tumors. The initial reports mentioned a median survival of close to 18 months, but these resections were performed without adequate or appropriate neoadjuvant therapy. If you see here, only 15% of the patients had received neoadjuvant therapy. But the later subsequent reports that we have, they show that they have comparable outcomes with the distal pancreatic tumors, standard distal resections, along with as compared to DPCARs. And the more recent reports where more neoadjuvant therapies have been used, you see that 23 months and 36 months of long-term survival is observed when an adequate TNT is delivered to these patients. Our own experience at TMH is with close to 18 celiac axis resections with 3 postoperative mortalities, and the median overall survival in these patients is 31 months in our series. We are analyzing the data and in process of publishing it as well. The factors which are essential when you determine these patients for resection is, of course, the age, the body mass index. Male gender has been seen to be a negative prognostic factor in their series for some reasons. But high body mass index, high ASA score, multivisceral resection, basically which increases the complexity of celiac axis resection, have a negative impact on the short term as well as the long term outcome. That is what the data is. Now, for the want of time, I will not go into much details, but I would urge everybody who's interested to look into these papers, these publications on complex multivisceral or extreme radical resections for locally advanced pancreatic cancers, particularly by Ino et al., which is a systematic review, and the other one which is there, which is also for use of total neoadjuvant therapy, how it is utilized, minimum of 8 to 10 cycles, radiotherapy when used in combination, all of that. And then when you have a CA19-9 response, then to offer radical resections. Almost all these series have shown survival in excess of 24 months with a morbidity and mortality which is acceptable. For superior mesenteric artery resections, in particular, the evidence is sparse. We all know that the 2017 HPB publication by Sirivardhane et al. That SMA resection should not be done. The median survival was shown to be only 11 months from a large database, but that was again older time. The recent papers, this is from Ugo Boggi from Italy. This is again a large series of 587 patients with vascular resections for locally advanced diseases, wherein there are 69 SMA resections, 86 common hepatic artery and celiac axis resections. And what was shown here in their series that the short-term outcomes were not inferior as compared to the other standard resections, as well as the other vascular standard resections as compared to the SMA resections. The long-term outcomes are yet awaited. However, likely going to be superior is what the author says, because they have previously published their SMA resection results, wherein a median survival of close to 30 months were observed in one particular group, and the other particular group had a survival of 16 months. So there is significant heterogeneity even after a proper appropriate case selection in their series as well. And obviously that remains our challenge as to how to select beyond CA19-9, beyond performance status, and beyond the responses that we assess in neoadjuvant therapy, after neoadjuvant therapy, what else at molecular level that we need to know in order to determine which patient would benefit in long term. When we do these major resections, again, in the earlier era, the mortality, post-operative mortality was in excess of 20%. But if you see the more recent reports, all the major morbidity and mortality is acceptable. Of course, it is higher than double than the standard resection. It is in the range of 6 to 8% of post-operative mortality. But of course, that is acceptable when we talk in context of locally advanced diseases, combined vascular resections, and the with neoadjuvant therapy, the R0 resection reported is upwards of 70%. So when done properly, of course, the risk is minimum, and then it definitely adds value. Of course, the alternative
Manish,
is
Dr. Arvind here. I think the time, can you, because we are worried about Shailesh catching his flight. So,
okay.
but
We'll
we are
wrap up.
loving talking, hearing you, but I just, in the
No,
interest of time.
I totally understand.
Don't
So
worry about me. I will make them delay the flight. I'll tell them that Manish and Ramesh are talking.
Great, great. I think I'm listening, liking listening to Manish, just in the
So
interest
I
of
will
time,
quickly
just to,
wrap it up.
yeah, yeah, yeah. Thank you, Manish.
Of course, the apprehension is that vascular resections add morbidity. That's the fear in surgeons. What we know is that R0 improves outcomes, but the morbidity is what we are worried about. But when we look at the other side, if we don't operate, the alternative basically it is worse. Standard chemotherapy alone, even with the modern chemotherapy, the survival is not great. Of course, we have the IRE and the SBRT, local ablative RT, as new avenues, but still far away from the outcomes that we see from surgery. The molecular and the immunotherapies will continue to evolve, but again, till the time we have these answers, what remains with us is the standard surgical resection for these cases. So to summarize, what I would say is that we have definitely come along in pancreatic surgery, in locally advanced surgery. First, we said that minimal invasive should not be, first we said pancreatic resection should not be done. Then we said minimal invasive should not be done. Then we said vein resection should not be done. Then we said artery celiac axis should not be done. And today we are all doing everything. And it's the matter of SMA and the combined vascular resection. It's the matter of achieving that technical proficiency and offering a safe resection to these patients. And then, of course, in high volume, well-established unit, this is definitely going to add survival. So I would highly encourage in these cases. That is where I would end. Thank you so much.
Yeah, I think, thank you, Manish. I think you covered extensively, I must say, the entire spectrum of the evidence that was there. And we would just now want to listen to the contrarian view from Dr. Ramesh. Professor Ramesh, the stage is yours. We are looking forward to hearing from you.
Sir, you need to unmute yourself, sir.
So I thank Manish for a very exhaustive description of the scenario. And I want to say at the outset for the purpose of this debate, I have confined myself to pancreaticoduodenectomy with vascular resection, because Distal pancreatectomies are an entirely different ballgame. Every case is a vascular resection. If you're going to operate a patient, you're going to do a vascular resection of some sort. Why don't we just do the logical thing and say, take it out all the time and do a Manish and forget about it? The categorization of pancreatic cancer into BRPC and LAPC is still a lot suboptimal. The dubious word reconstructable is employed, and that is a major cause for concern because Manish can reconstruct things that others can't. We know that less than 180-degree arterial and reconstructable vein means a borderline resectable cancer. And here, upfront venous resection was approved by the ISGPS as early as 2014. However, if you have locally advanced cancer, we are talking about greater than 180 degrees abutment of the artery and extensive involvement of the vein. And it's just not collaterals. If you have extensive involvement into the, into the small bowel mesentery, the more proximal it is, the more difficult it is to resect. And then the philosophical question is whether we should be going ahead or not. So many papers, including most of my papers are in the last 5 years because that's what is relevant to us, have suggested that patients with LAPC are never considered for vascular resection. Once they have LAPC, they are referred for induction chemotherapy and occasionally show a response that make them candidates for resection. That's a rather bleak situation, which is not what Manish said. Manish said you can resect all of them, it's fantastic and stuff like that. It's not a great situation because very few patients really become candidates for resection. And 100% of them may get chemotherapy, but very small numbers actually reach the operating table with an R0 resection or whatever. LAPC has many stages, and fortunately, and it's very convenient for somebody who is pitching for resection, that you can have varying degrees of vascular involvement, as Manish also emphasized. But if you look at the bottom group, that if you have non-reconstructible tumor invasion of the superior mesenteric vein or the portal vein with portal hypertension, and it's obviously a no-no, but everywhere else you can dabble with the possibility of resection. And all this is very hair-splitting, impractical, no standardization, and different radiologists have no agreement sometimes, and the kappa value is very poor. So really, if you ask me, are vascular resections justified in locally advanced pancreatic cancer? Heck no, would be my answer, because the focus would be on neoadjuvant therapy and salvage surgery. And I'm disappointed that Manish never referred to the word salvage, that this is essentially what is possible in pancreatic cancer at this time, that we salvage patients with a good response to chemotherapy or chemoradiation, depending on the continent that we are in. There is an implied question also that would you have, if you have a locally advanced pancreatic cancer, whereas for BRPC, we are allowed to proceed to an upfront resection, provided our imaging is perfect. And unfortunately, contrast-enhanced CT does underestimate the disease extent in many cases. We can try a likely vascular resection upfront rather than neoadjuvant therapy. And that's an implied question in this debate. And really, it's a philosophy that we are looking at here. You have a locally advanced cancer, would you have the courage to suggest to the patient that he or she should undergo a resection? So I'm just going to play a devil's advocate and look at the situation as we see. The three things I always look at when I look at a procedure: safety, applicability, and efficacy, the SAE. When I look at applicability, this is not a large number of patients. And even in the largest centers in the East and the West, the numbers of resections in a year are less than 10. And that's, somebody who does 200 pancreatic resections do 10 or 15 pancreatic vascular resections. And that is the testimony to the fact that this is not something that we should recommend across the board. We can't just say at the end of the debate that, well, vascular resections are not only justified, but recommended in pancreatic cancer. They are salvage operations for a small number of patients. And in fact, the French recommendations, a little older, 6 years old, but also said that we need patients who have good performance status. And that's not something that Manish referred to. We need patients, only the good performance status, only the good eggs ever come to vascular resection. If the patient has poor performance status, there's no. It's in Tata, in any hospital. And if neoadjuvant therapy has been exhibited, then the question arises that you can salvage. And there's no question that if you have good performance status, you have good biology, you have good surgical experience, you have good surgical expertise, and the infrastructure, you can obviously go ahead and do any operation you want and you reconstruct anything. What about safety? The real world evidence that Diksha and Manish and others, and including all of us, presented a 6.1 90-day mortality. And that's the reality of the fact that the last 100 pancreatic resections, our mortality was under 1% when we did not do a pancreatic vascular resection. So there is a definite burden as far as survival. If your patients are going to die after operation, they're not obviously going to become candidates for 5-year survival. So operative mortality is an important index of long-term survival. And we did not describe the 16 arterial resections because we talked about portomesenteric vein resections, but that would have been interesting to know what the collated evidence was. In fact, if you look at it, if you did a 3 or 4 grade ISGPS, there was a 4.1 times risk. And we're talking about centers like Tata and centers of many very estimable centers, 4 times mortality risk. And that's not, to my mind, easily acceptable because that's something that we have to work around. So what about efficacy? 4 meta-analysis has been published from 2016, 2017, 2022, and 2024. Generally, the story has been of a slightly higher mortality, more R1 and R2 resections, and lower survival with larger tumors and perineural infiltrations. More PPHs in the third meta-analysis. And in the fourth, everyone had neoadjuvant therapy. And that was an important eye-opener that really hardly any patient reached vascular resection, especially in a locally advanced pancreatic cancer without neoadjuvant therapy. And if you look at the comparison between, median survival and 5-year survival in those who had venous resection and those who did not, there was a substantially significant poorer survival in all of these patients. They are okay with salvage, but it's not okay if it's a primary upfront resection. There is also a premise that Manish said that vascular resections will improve local control. Is that true? If you look at a paper published a month ago from Taiwan, it showed that the RO resection was much higher in the patients with no venous resection, and the lymph node harvest was comparable. The difference in local control was also not different in the two groups. And in fact, if you look carefully, the patients who really benefited after venous resection was those who did not have histological evidence of vein involvement. Those who had histological evidence of vein involvement fared the worst. Surely that is a biology thing, because once it sort of spread through the portal venous system, it was a game, set, and match finished. So patients who had negative histology, and only 40 to 60% of the resections that were done in India and abroad have had actually histological evidence. And that's something we have to work around. Are we doing a venous resection just for surgical machismo? Is the question that I would ask. I feel that therefore radicality is not synonymous with vascular resection. And if you look at discontinuous disease in the uncinate process and the mesoalcinate and the mesojejunum, which is a continuation of the uncinate process, and this is something I've been screaming from the rooftop, that if you do not do a proper periadventitial or subadventitial dissection of the SMA, just doing a venous resection is not going to make any improvement in radicality. So it is important to do radical surgery. If the vein is involved, you may resect it. That's a different matter. But you cannot make venous resections a subject of much debate because there is nothing in the venous resection. So the technical challenge of venous resection may have been complete. We may be able to do it in many centers, but not all the centers which do pancreatic surgery. And we need to upgrade that as well. But we have to understand that the survival depends on other factors. CA19-9 levels, ASA and R0 resection. And R0 is so difficult to find in patients with pancreatic cancer, whether it is N1, whether it is R0. If you take out the vein and the vein is R0, you can still have disease in the mesoalcinate, and that can be the final frontier. So what about arterial resections? There have been several systematic analysis, and all of them have talked about higher mortality rate. This is the last one published this year from South Africa. And almost the summary of that was almost never upfront, stable disease after chemotherapy. They concede that, as in venous resections, preoperative imaging and post-radiation imaging is not precise in assessing the extent of the vascular involvement. We have to accept the fact that currently there is a 3.28 times higher risk of mortality. But the morbidity is comparable now with improved technique, as Manish referred to. But a threefold increase in R0 resections was achievable, and that's an important point that Manish would take heart from. But I would like to say that when we think of especially upfront vascular resection, we should curb our surgical enthusiasm, not progress to surgical machismo. We should not make it a case of raising the patient's hopes, inflicting considerable morbidity and some mortality, and all that, achieving all that at substantial costs and no substantial difference. And radicality, as I said, is not synonymous with venous resection. And I would like to just use Manish's slide himself, that it's still biology the king, imaging and case selection is the queen, and technique merely the manservant. Thank you very much for your attention.
Thank you, Professor Ramesh. And Manish, quick 1 minute.
1 minute.
You want to make button? Yeah, very quickly. Yeah.
So very quickly, of course, I don't know if I was not clear. All these resections are after neoadjuvant therapy. That is a given. And even I mentioned that even we should use total neoadjuvant therapy. And it's not a very small percentage that will come for surgery. The reports mention 60% of patients will come up for surgery. And in those who will operate, again, the evidence says that 70% can receive R0 resection. So that remains there, and that is absolutely no doubt that all of this cannot be upfront. Even borderline resectable tumors should be operated after neoadjuvant therapy. That is given. The patients do tolerate it well and do have good performance status, and we are able to operate in close to 60 to 70% of these patients. That is there. Now, high volume center and experience is very important to give the best outcomes. If you see Mark Truti, Michael Kendrick, from Japan, Ugo Boggi from Italy, Chris Wolfgang, all of these, Marco Del Chiaro, all of these centers are strongly pushing and doing radical surgeries for LAPCs. And I'm sure that they are not doing this without any reason. They have seen and they have published their outcomes, which have shown encouraging results. And we should also devise our systems well so that we are geared up for performing these radical resections in safety. And in, of course, rightly selected patient. I was also mentioning again that if biology is permissible, if conditional factors are permissible, then we should not say no purely because of anatomical classification of LAPC. I think that is where I would end.
Yeah. Thank you. Thank you, Manish. Any quick thoughts, Professor Ramesh?
No, I think my point was very clear that it's not as rosy as Manish says.
Yeah.
When you have selected series, it's not all comers, and we don't know the fate of the all comers. If you have, let's say, a certain number of patients who gravitate to a center like Tata over a period, and a good number of them have vascular resections, and if the outcomes are good, it does not sort of allow you to use the word justified. Because once I use the word justified, I am sort of giving everyone a free hand in doing a vascular resection at any point in the patient's course. It has to be in qualifications, and it's not just enough to say biologically acceptable. I differ with Manish's opinion that the response to chemotherapy is also that robust. In the meta-analysis of 5 modified FOLFIRINOX that was published in 2022, the response rate was 45%. And so we can see that a huge number of patients could not in any way come to surgery. If they came to surgery in a given center, what we are not being told is what is the denominator. And because we do not know the denominator, we are all excited. We read the papers and we say, okay, now vascular resection is the way to go in all these patients. We know that imaging is absolutely suboptimal in reassessing. If you have CA99 levels which have risen in the beginning, that's a great boon that when they come down, you can use it as a good marker. But sometimes CA99 levels are normal in the first place and then they are no use at all. And then exploration is the only way. And then you have a whole slew of operations. That is salvage. And then the patient clearly understands that this is salvage, and that the word salvage must be incorporated in whenever we talk about justifying major vascular resections for pancreatic cancer. And that's my premise.
Yeah, thank you, Professor Ramesh and Manish. And now I would like to hand it over to Professor Shailesh. I think I must again sort of re-emphasize that really appreciate Shailesh for your time and effort despite your travels, agreeing to sort of give your expert comments. Really commend and looking forward to hearing from you more. And I'm sure everybody is.
Thank you, Arvind, and thank you, Manish, and thank you, Dr. Ramesh, for a very good comprehensive coverage of the topic and discussing the pros and cons. You have said that expert comments, so yes, I will refer to some of the statements of Manish and Dr. Ramesh, but first I'll try to give you my own independent assessment. We need to understand that the prognosis of pancreatic cancer is one of the worst in terms of the progress that we have achieved in the last 80 years as compared to any other cancer. That's statement number one. We can debate, we can talk, but that's the fact. The second bit is that we have these classifications, and for a beginner, these classifications are very good. They give you some sort of a broad roadmap to work in your clinic. And then we have the NCCN, the AHPBA, Mark Talamonte, 2009. I started getting interested in this in 2007. We published our first series of 12 patients in 2011 of vein resections because they were formerly being considered as advanced pancreatic cancer, but now we could resect the vein. Having said that, the more classifications we have, the more it indicates that no one knows anything. Let's accept this also very clearly. There is no confusion. Yes, you can be a Srikhande, a Ramesh, a Bandare, a Marco Del Chiaro, a Buchla. But the fact is, this is a very small numerator as to what's really going on the ground. Statement number one. Statement number two, I did not completely agree with one statement of Manish that biology is not equal to vascular involvement. It can be equal to vascular involvement. And I think that point was very well brought out by Dr. Ramesh that path involvement of the vein versus non-path involvement of the vein, there is a big difference in survival. So it's not just a question of location of the tumor and geography. It's clearly the fact uh, following all the principles of oncology for any solid tumor, and that applies to a cancer which is inherently aggressive. So you have to factor that aspect also. What came out well was that technically we can achieve a lot of progress, that's clear. And there is a so-called renaissance of more aggressive resections because we have had better progression since the time we started using gemcitabine, which was the gold standard for about close to 3 decades. And then we got FOLFIRINOX in 2011 as in the palliative setting. And in 2018, the same author came up with the adjuvant chemotherapy. But I do want everyone to study that paper, that there is a huge amount of selections and ifs and buts, which has resulted in the 54 month, 5-year survival when you complete the chemotherapy, the FOLFIRINOX chemotherapy in the adjuvant setting. Having said that, let's not undermine that quality of surgery is important because that survival was achieved only in the group of patients who got R0. So now coming to the specific question on hand, this is the background that I would like to say as an expert. And then the second background is locally advanced pancreatic cancer. Um, I do not agree with Manish that 70% of locally advanced pancreatic cancers are resectable. Technically, yes, I think every tumor in the body is resectable and everything is reconstructible nowadays. You can do multivisceral resections and you can create magic with surgery. But I don't think that's the point of this particular webinar. The statements of, that Siri Vardena is 2016 and Ugo Boggi study is now and that they are relatively old, I would not agree. I have seen the Buchler publication of Malberg in 2011, which is just a little over a decade. And if at all there is a group which has really taken on vascular surgery in a big way, was exactly during the time when I was doing the Warren Fellowship in 2005. So I exactly know the Heidelberg story inside out. Having said that, that data is not old. That data is very relevant today. And we need to understand that there is high quality surgery. But even in these centers, as pointed out by Dr. Ramesh, we don't really have a good access or a good idea about the denominators, and that's important. So when it comes to artery resections, I think in terms of sheer high quality evidence, we have virtually no evidence to show that we are making a big difference with SMA resection for pancreatic cancer, barring the selected group of patients, which is a highly selected group beyond our technical abilities, that the ABC understanding of pancreatic cancer, anatomy, the biology, and the condition of the patient, A, B, and C, if all three of them are excellent, you will perhaps get 2 out of 10 which are now resectable and should be resected. So I do agree that a highly selected group of locally advanced pancreatic cancers ought to be offered resection. But in my own experience, I would not be offering SMA resections for 6 patients out of 10. I would be perhaps offering SMA resections for 2 patients out of 10. Yes, the common hepatic artery and the celiac axis is not being discussed. We have data that if we give good neoadjuvant, again highlighting the importance of the multidisciplinary nature of this cancer. For example, it's hard for me to believe that a good friend of mine like Mark should publish this paper in 2016 with hardly anyone getting neoadjuvant chemotherapy and having an 18-month survival. But now everybody agrees that if there is any vascular involvement, vein or artery, you need to give chemotherapy. Now, the counter is also to be kept in mind that the chemotherapy is of an extremely average quality. We have made progress, but finally it's FOLFIRINOX and we are stuck on it for the last 7 years. So please do balance that out as well. One more statement was that it's not just the completion of adequate treatment and R0 resections that matter, the extent of resections also matter. One vein resection, one vein and one artery resection, one vein and two arteries resection, all of them have worsening outcomes. This is documented. The other bit that we need to understand is that even the type of vein resections, our own study published, we initiated this a few years ago, and I take this opportunity to thank many of these centers. Good work by Diksha and Manish. But even for type 1, type 2, type 3, and type 4, the morbidity and the outcomes were worsening for the 4 different types of vein resections. So I think again, the extent of vein resections matters. Last but not the least, both the speakers, yes, Dr. Ramesh to some extent touched upon it, but both the speakers did not make any reference to what are the quality of life outcomes when it comes to, let's say, we selected the patient, we did a great job. Some of them went home reasonably in time with acceptable morbidity, and many of them did not go home in acceptable period of time. And what about their quality of life and their long-term survival? I think this is an important issue, and there is one study which we would be very soon initiating. You offer treatment neoadjuvant, and then they go for surgery, and after surgery, you evaluate quality of life. The other group, we initiate neoadjuvant treatment with the intent of offering surgery, but for whatever reason, we do not offer them surgery, whatever. You can call it surgical reluctance, patient reluctance, one factor not in favor, etc., 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 and then comparing their quality of life outcomes. I think we should never forget that as our technical prowess increases, We need to be first good human beings who are excellent, wise surgeons working as a member of that patient who's undergoing pancreatic cancer. With that, I think I'll stop here and want to hear if there is something more to be discussed. I can't hear you, Arvind.
Sir, you're
Yeah, sorry, I was muted. Thank you for your insightful summation of the things, of course. And I think I see Professor Ramesh's hand up, but then prior to that, I would just invite Dr. Toprani if he wants to sort of chime in here and sort of.
And one bit, we have virtually no RCTs, which tell us about
Yeah.
any superiority anywhere.
Right.
Yeah.
No, I think that is the reason why this was brought for a debate, you know.
Exactly.
So because it's perspectives of everybody, and I think more or less there was a lot of commonality. Although I'm not a domain expert at this, but I could find a lot of commonality between all the three experts in you.
Yeah.
Yeah. Dr. Toprani, very briefly, would
I
you want
was
to?
mesmerized by these three speakers, and I would urge you to go ahead and go ahead with the program.
Okay. Professor Ramesh, your hand is up. You wanted to make any quick point?
Yeah, having opposed Manish at every step, it's my turn to now give him some substantial relief as someone whom I'm very fond of. The first thing I want to say is that if you have an accessory right hepatic or an aberrant right hepatic which is involved by a tumor, or if it is close to the tumor, resection is a must. There's no need to back off. There's ample data for that. And he did not bring it up, but I can give him the data if he wants. The second thing is the reason why only 40 to 50% of tumors have histologic involvement is because surgeons, all of us, have been trained not to dissect the superior mesenteric vein of the tumor and to let the tumor hang on the superior mesenteric vein. And when we do that, our clinical perception of involvement may be slightly erroneous. And then we tend to go on the side of safety and take out the superior mesenteric vein segment. So I think that is why 50% is only positive. The third is that if I had to argue Manish's case, the importance of, he did mention that if to condemn patients to long-term just chemotherapy or palliative chemotherapy would be disastrous, or to leave them alone with best supportive care. But if surgeons, surgical oncologists, gastroenterologists, whatever you like, do not actively examine patients frequently, and this is something that does not always happen in a multidisciplinary forum. Patients are often lost for several months while a program is being done. When is the window going to be available? Is always a big controversy. Sometimes you may have to do more and more images, more and more examinations, select the right and optimal time for patient interventions, and then perform it with exceptional skill. Whether you use whatever technique that was described is entirely different. And you have to get patients home well. And that's an important, bottom line if you want 5-year survival. So I think frequent re-examination by a multidisciplinary group, which also involves a surgeon who deals with pancreatic cancer, is critical if you want to salvage more patients. If you leave it in the large domain of multidisciplinary therapy, then sometimes you lose the window of opportunity. So I have to support Manish because he's my good friend. So thank you.
Thank you, Professor Ramesh, again. Thank you, each of you all, for your insightful insights into this. And as you brought out, Professor Ramesh, we have a star-studded multidisciplinary panel that's going to come up on borderline resectable pancreatic cancers, moderated by Dr. Vivek Agrawala. And the panelists, Vivek, do you want to call them?
Okay, I take your leave. Bye-bye.
Yeah.
Thank you very much.
Thank you, Shailesh, for sort
Good
of
night.
joining.
So,
And
Shailesh, have a safe trip and be
Thank
good.
you. Take care.
And
Bye-bye.
be good.
Bye.
Thank you, Silas, for joining at a short notice.
Pleasure. Bye-bye.
Yeah.
Vivek?
Yeah, can someone allow me screen sharing?
Sure.
Yes, sir.
So as you are sorting it out, I would invite the panelists to join as well.
Yeah.
Dr. Shravan Nadkarni from Raipur, Dr. Sania from Mumbai, Dr. Bhushan Zare from Pune, Dr. Vamsi Krishna from Hyderabad, Dr. Shirley Lewis from Manipal, Dr. Devasha from Ahmedabad, and Dr. Soumya Panda from Bhubaneswar. Welcome all. And Vivek, you're set?
Yeah.
Yeah, great, great. I think over to you, and you take the case along with the panelists.
Thank you. So I think we had a really wonderful discussion amongst two very great surgeons about the resections, and it was a great insight to learn. And now we have a full MDT panel with 2 medical oncologists, 2 radiation oncologists, 2 surgical oncologists, as well as a radiologist. So before wasting any time, let us go ahead and start the discussion. So we would want to discuss regarding the definition of BRPC, the anatomic as well as the biologic aspects, the neoadjuvant strategies, response evaluation, surgical challenges, and post-surgery, what strategies are optimal, and if surgery is not done, then what are the optimal ways, and what are the future perspectives as to how we can improve on the results currently. So this is what we have, a basic overview as to a resectable, a borderline resectable, locally advanced, which is unresectable, and a metastatic disease. So, and before, going, I think we already have, a radiologist there as well as a surgical oncologist. So maybe I would ask the surgical oncologist, Dr. Shanea, as to, an upfront, how would you want to work up your patient for evaluating, a potentially resectable pancreatic cancer?
Hi. So I think apart from an imaging, for which a CCT, thorax, abdomen, pelvis is generally more than enough. You have some amount of data on adding a PET CT, but I don't generally advise on adding a PET CT because you have good enough information on your contrast enhanced CT apart from a CA19-9 for a biological assessment and a biopsy. Based on that, anatomically, you define exactly whether you want to do, whether it is a BRPC or an LAPC. For LAPC, I generally use the John Hopkins definition that Jin Lee has proposed based on the artery and the vein assessment, which gives you a very good correlation whether resectability is possible. They've divided into 3 groups. That's a very good and an excellent paper to read for anatomical assessment. And then based on that, we're going to give you a new adjuvant strategy.
Yeah. Dr. Shravan, so any particular, kind of a pancreatic protocol CT scan or a triphasic, something that you'd want to stress before you, send your patient to the radiology over for the scan, or just a plain, CCT is well enough? Because sometimes the quality of the CT scan can be really, valuable, or can be to change your management. So, Dr. Shravan, what is your practice?
So there's a big emphasis on the quality of CT. Usually patients that we see in the OPD come to us with some sort of imaging that they've already got done outside. And if it is a good high quality triphasic CECT, then it is acceptable. But I usually insist on having the DICOM images because that helps me plan the surgery better. If the imaging that has been already done is not satisfactory as far as these aspects are concerned, then I get a pancreas protocol, triphasic CECT, chest, abdomen, and pelvis. The chest helps stage the disease. The triphasic and the pancreas protocol helps give me good delineation of the tumor anatomy and the vascular structures. So just for the benefit of our attendees, a triphasic scan involves a late arterial phase, a portal venous phase, and a delayed phase. So we have specific requirements for each of these phases. That is why we have a better resolution of the tumor as well as the vascular anatomy that is concerned.
Dr. Shravan, suppose you have done a CT scan and it appears like a completely resectable disease. Now, there are 2 or 3 important questions that, as an oncologist, not a surgical one, but still, it comes to my mind is that if it's resectable, would you want a biopsy to be done? Or would you be happy to go ahead, straight with the surgery? Number 1. And number 2, would you still discuss in a MDT if it appears as a resectable pancreatic cancer?
So answering number one, would a biopsy be required in the present scenario? We still don't have robust data to suggest that neoadjuvant treatment would be required for resectable pancreatic cancers. So till such a time that we have strong data which says that neoadjuvant therapy is required, that would make a case for a biopsy in all pancreatic cancers. But in the present scenario, a case where there is imaging finding which is objective enough to suggest that it's a head pancreas lesion or a body or a tail or whatever, and the patient has symptoms of obstructive jaundice with a raised CA19-9, all pointing towards a possible periampullary or a head of pancreas primary, I would not go for a biopsy. I would take the patient up for upfront resection. Of course, with due respect to the bilirubin level and other parameters. So biopsy required, yes or no? In the present circumstance, resectable pancreatic cancer, not required. The second question is whether we would put them through an MDT. Yes, of course, every patient of pancreatic malignancy should go through an MDT. Because it is not just a surgeon's game here. Oncology, as we all understand, is a team game. So we need to have good nutritional optimization. We need to have radiology inputs that can tell us about arterial variations. We have had the opportunity to have a good training where we assess the CTs good enough, well enough by ourselves, but some valuable inputs from other streams also help. So yes, I would put them through an MDT as well.
Great, great. Third, one thing that maybe Dr. Shanaya can take this up is in resectable pancreatic cancer. Would you go with a separate, staging, peritoneal staging, laparoscopic, sort of staging, or this is something that you usually take up during the surgery itself?
So for a resectable pancreatic cancer where the CA19-9 is not more than 500 in a non-jaundiced patient, if it is a pancreas cancer, usually you would not require. However, if your CA19-9 is on the higher level, I would still refer the patient for neoadjuvant chemotherapy rather than operate upfront. And in those situations, I would not prefer to do a staging laparoscopy at that moment. However, at the time of final surgery, when your CA19-9 has come down and your patient is otherwise in a resectable status as well, defining the anatomic criteria, I would start off with the staging laparoscopy and then go ahead with the surgery.
Great, great.
I would just like to add a point here.
Good takeaway points that we have taken is that in a resectable pancreatic cancer, biopsy is not essentially required, but still, an MDT discussion is something that is really vital and should be practiced. And if it is a borderline resectable or a unresectable, then definitely a biopsy is something that will be required. And workup does include CA19.9 because it just gives you some more idea about the biology of the disease. Of course, the status of the patient, comorbidities, the bilirubin, and all these are also taken into account. Now, one of the differences and one of the issues that we have had in this country while managing a disease like pancreatic cancer is definitely the MDT disagreement and institutional differences. So a patient which is resectable can go to TMH and become an unresectable, and and the same patient when goes to AIG probably can become a borderline resectable. So this is one of the challenges, and maybe I would bring in Dr. Vamshi to sort of say that how much these institutional differences play a role and how to optimize this kind of situation, more standardize the definition so that we have less of these differences. Dr. Vamshi.
So, Vivek, honestly speaking, if you ask me, I don't think among the institutions with a high volume or a high burden, I don't see these many differences. I mean, mostly the tendency to, go for a surgery upfront, even if there's a doubt, is not so much. So I don't really agree there's a huge difference in MDT or institutional. I think every MDT follows a clear path. Probably the difference, I would say, is maybe a bit more stress on neoadjuvant versus less stress on neoadjuvant. That's the only difference. Resectability, if you have a good scanning, it's reproducible. So I wouldn't say that if I call a patient borderline resectable, he'll go to Tata and become resectable next day. I don't really think that happens. Probably the surgeons can comment on that, but I don't think there's such a wide variation as you seem to say in high volume centers.
Yeah, Dr. Shravan, any comments on that? Because there are capacities for different vascular resections. There are capacities for different, and it was insightful to listen to Dr. Manish's lecture, where he was talking about even reconstructions in the celiac axis and reconstructions in the hepatic artery, and these are something that makes it different in different yeah. So maybe yeah, Dr. Vamshi.
No, listen, you're confusing two things. You started by saying potentially resectable, and now you're talking of reconstructions. When it's reconstructions, I don't think anybody would go upfront with a reconstruction plan. Like Dr. Shikhande was also saying, and like Dr. Shawn, like I think Dr. Manish was talking about, most of these patients would get some form of neoadjuvant. The patients where you're not sure of a reconstruction prior to radiology on table, you need to do a reconstruction. That's a different set altogether. I mean, if you upfront know that you need to do reconstruction, I don't think any center would push for a surgery upfront. That is my take. Again, the surgeons can comment. Sorry for cutting.
Dr. Shravan, you wanted to make some point and maybe comment on these kind of things. And another question is something that often happens, that a patient has already worked up at one center lands up at another center. So, or maybe your patient is resectable. So how early would you want this patient to undergo a surgery? And if a surgery is not done in this much days or weeks, would you want to have a restaging scan in order to just make sure that the stage is not changed as you open the abdomen?
So just a word about the discussion that was going on between you and Dr. Vamshi. So defining whether a case is resectable or borderline resectable or locally advanced should actually be uniform. There should not be much difference between institutions. Whether to go ahead and resect arteries, whether that capability is available, that infrastructure is available. There was a very nice slide that Dr. Ramesh put up, that you have all these resources with you, and that makes you kind of lean towards going ahead, going radical. So that is something that can have institutional variations. But as far as defining whether it is LAPC or BRPC should not be an institutional function.
Agreed.
The second thing is you asked the time that is spent in evaluation and how quickly would you want a re-imaging or a restaging or something like that. So usually my practice is imaging that has been done within a month should not change the stage too much with respect to the CA99 levels, because the tumor marker level is very, very important and relevant here. If the patient is developing some sort of biliary obstruction, some sort of duodenal gastric obstruction, some symptoms that have cropped up in this interim period, then I would definitely want to get a repeat imaging. One word again about the CA99 level is, in an obstructed system, the CA99 is always going to be high. So even if the patient is who has obstructive jaundice has a CA99 upwards of 600 or 700, I would wait for the jaundice to come down and repeat a CA99 level to actually get the relevance of the CA99 in this particular scenario.
Okay. Dr. Shravan, at what level of jaundice are you happy to operate upfront without stenting?
So we have the ballpark figure that we have used is about 15 milligram of bilirubin. But I know from experience and even I've seen seniors, Dr. Srikhande, operate at even higher levels of bilirubin. But one word of caution is that with increasing bilirubin level, the coagulopathy is pretty significant, and we could have a scenario of not so great.
Dr. Soumya, at your institute, what is the usual bilirubin level at for upfront surgery without a stenting?
So mostly the surgeons they discuss. I think there was this borderline resectable and locally advanced. If you ask the surgeons that whether this case is you are discussing about resection, then the discussion will on the resection.
No, resectable or upfront resectable. At what bilirubin level, in your institute, they go ahead with resection versus the stenting?
So I have seen them less than 15, they will go for surgery, but more than 15, they will not take it up until they have got a pre-op biliary drainage.
Okay. So this is the radiographic classification, very standard. Dr. Diva, anything you'd want to comment, because I will hardly get an opportunity to bring you into discussion if not at this point of time. Dr. Diva, are you there?
Yeah. So basically, Dr. Shravan and Dr. Sanaya both have discussed that imaging perspective. Ideally, a good CT with a multi-slice scan where we do a triphasic. Here, the triphasic means same late arterial, which is very important because early arterial, where there is a faint filling of the arteries, will not give the proper anatomic details of the arteries. And so the late arterial, that phase is most important to begin with, to the normal anatomy of the arteries, whether there are any arterial variations or not. The portal phase, where we see the maximum pathology, which includes the solid tumor, the extent of the pancreatic tumor, and the relationship with the adjacent vasculature, plus the involvement of the transverse mesocolon or the mesentery, the proximal root of the mesentery. So all this informations what we get, it is in the portal phase where we have both the things together. And if when we talk about the abutment and the encasement, those details we will get in the late arterial phase. So these are the phases where which helps us to decide about the resectability or the vascular resections in that
Great.
context.
Dr. Diva, so I was going through the literature, and there's something very interesting that I got, that the position with respect to the duodenum is also something very important. And the tumor, if whether the invasion of the SMV or the portal vein, if it is exceeding the inferior border of the duodenum,
Correct.
it is different, because if it does exceed, then it is unresectable, whereas if it is not exceeding, then it becomes a borderline resectable.
Very true. So basically, what we look for the root of the mesentery, which is very crucial from the imaging perspective, and there are very subtle findings which we need to observe. So as you rightly said, that when the tumor is exceeding from posterior and inferior aspect of the duodenum, that forms the root of the proximal root of the small bowel mesentery. So it is very important to mention about the tumor extent inferior to the duodenum, plus even if you don't see the direct extension of the tumor, but if you see just any stranding or nodularity even in that region, that needs to be discussed with the surgeon.
Great. So, Dr. Shanaya, you were discussing the biologic aspect of the tumor as well, and one of the features of the biologic aspect is not only the elevated CA 19.9 but also lymph node positivity. So, Dr. Shanaya, what is your usual practice? At what level of CA 19.9 would you rather consider it to be a biologically borderline resectable and still anatomically resectable? And what about the regional lymph nodes? If the regional lymph nodes, peripancreatic nodes, they are enlarged and they look to be pathologic or involved, would you still push the patient for neoadjuvant, or would you go ahead with the resection?
So I think it is very well established that a CA99 of more than 500 is something that we categorize as VRPC, and something that you would want to give neoadjuvant chemotherapy for. Although there is no such clear-cut demarcation for nodes, if you have, but a very particular point is that if you have some enhancing node on the left aspect of the SMA, that is something that is usually not a template for your usual pancreatic duodenectomy. And in those cases, you would probably consider giving neoadjuvant therapy first.
Okay, great. So again, nodes on the left template is something that you are really worried about, and would you rather consider them to be biologically borderline resectable, and would you push them to neoadjuvant treatment, correct?
Yeah, that's true. Apart from a lot of things, and apart from assessing the mesopancreas and a lot of other things that you're going to certainly look on the scan,
of course.
But most of the times not reported. So that is something that either a radiologist or a surgeon who's assessing your scan is going to tell you.
Yeah. Dr. Diva, any role of PET CT scan while evaluating those lymph nodes? Because, they can be reactive, or they can be, so would you recommend PET CT scan, or the CT scan, a good triphasic CT scan is good enough to tell you whether the nodes are involved or not?
Ideally, the good triphasic CT scan done with a proper protocol, it is good enough. But yes, the sensitivity of picking up the nodes, I would say particularly non-regional nodes, is of course it is the sensitivity is more of the PET CT. But again, there comes a question of the specificity. Particularly in Indian setup, we may see a lot of inflammatory and granulomatous adenopathy. So again, it's a question of so whenever we are reading the either whether it is a CT or a PET CT, we also need to correlate the level CA 19.9 levels and the disease aggressiveness. And on that basis, we judge it's not just about the SUVs. It's about the morphological correlation and the disease correlation, that what is actually happening with that patient. So, of course, the sensitivity, so far they say that the PET has the sensitivity to pick up the nodes of metastasis of 8 mm or more. So
Okay.
that's the one thing, but we have to consider the differentials, of course, in mind.
Yeah. So, Dr. Vamshi, so if I would say that, in patients who have a CA 19.9 very high, in additional to a good, CECT, I would probably want to do an additional PET CT scan also, because that will improve my sensitivity of detecting local nodes as well as distant mets. So, would you say that the statement is correct and, should be incorporated into practice? What is your opinion, sir?
I don't think a PET CT really adds huge amount. Like Dr. Deva is saying, if you have a CT showing proper nodes which are non-regional, you know they are non-regional nodes. You see para-aortic, you see distant nodes, you take them as positive. A good quality triphasic CT has probably more information than a bad PET CT, because not all PET CT scans, remember, would include a triphasic CT. They usually just do a PET and a single phase CT. So it is more useful to do a triphasic CT. The only situation where we do it differently in our center is because we get a triphasic PET CT scan. So we do a PET along with a triphasic CT if patient has just done a single phase outside. Then it helps to do one scan, because you get to cover the chest as well and stuff like that. But a good, well done triphasic CT abdomen is good enough. PET, I don't think will give you anything extra over it. You can do a staging of the chest separately. Unlikely for pancreas to go to other parts like bones and other things. So this is good enough. That's how we.
I totally agree to Dr. Vamshi, because if I talk about my institute, at least the CT scan is 128 slice or in a plain CT, but in the PET the CT is actually 64 slice CT. So our radiologists are really happy with the CT scan, and not really happy with the quality of the CT of the PET scan. So I would be really happy with a good quality CT rather than a PET CT. So going ahead, I think this point is already taken, and I think the surgeons would both agree that the biologic perspective is taken into account, and the decision making. So upfront surgery, in borderline resectable, I think this is not something that is. But in routine circumstances, maybe I would ask Dr. Shravan as to what are his R0 and R1 resection rates, and when it talks about a kind of a resectable or borderline resectable, if sometimes is taken up for upfront surgery. What do you say, Dr. Shravan?
Am I audible?
Yes.
Yeah. So R1 is something that I'm really worried about, because these are patients who have been deemed resectable, where I have understood that I'm able to achieve an R0 resection, but then ends up with a histopath report which says that the tumor is within a millimeter of the resection margin. So this brings into perspective the LV1, LV2, and LV3 levels of dissection. So in case of a resectable pancreas, where it is a head of pancreas periampullary tumor well away from the vessels, then a LV1 would be good enough. But in any other scenario, like vein involvement, then LV2, and if arterial abutment or something, then a LV3. So that would bring down the R1 and R2 rates, of course. I am yet to evaluate my outcomes as far as what are my R0 and R1 rates, but so far, thankfully, I have not had too many of the R1 cases. So we have had good results. any patient who I feel I will not be able to achieve an R0, especially in BRPC, vein involvement, arterial involvement, would go through with a neoadjuvant treatment.
Yeah. So talking about like neoadjuvant, I think this is something that has been quite discussed in clinical guidelines as well as the different trials. And does the selection of patients is something that is really again very heterogeneous, and that is the reason why most of the clinical trials have been very small when we talk about neoadjuvant chemotherapy in resectable or borderline resectable pancreatic cancers, and you hardly can draw much superiority results out of these trials. So obviously the rationale that is there is same as everywhere, where you are dealing with more occult metastasis, maybe reducing distant relapses later on, biologically selecting your good patients for aggressive surgeries, and leaving out your aggressive tumors who might not sort of benefit, and probably giving them more better quality of life, and increasing the tolerance to chemotherapy also, because you are going to give a good chemotherapy free interval during the surgery, and then this also improves the chemotherapy tolerance and helps your patients to complete the total 6 months that sometimes may be difficult, and all those giving chances to improve their health and all. So Dr. Soumya, what
Dr.
about the
Vivek, sorry to
regimen? What is
interrupt
your...
you.
Yeah.
Dr. Vivek, sorry to interrupt you. Dr. Ramesh wants to make a couple of comments on PET and LV123.
Yes, Dr. Ramesh, I am not able to see.
Thank
Yes,
you.
yeah.
I just wanted to say that PET, even though first up there is no real indication for a PET unless your CA99 is very high, but still patients with high risk, now increasingly when we are embarking on an upfront resection especially, you don't want to be caught napping because you discover that there are metastases elsewhere. So I have gone away from not doing a PET to now including a PET CT. And while you said it is 64 slides, 64 slides is good enough for us. We don't need 128 slides and 64 slides, but an excellent person to look at the images with you. That's the one thing about the PET. The LV1, L2, L3, LV3, Dr. Nadkarni, I have a slightly different suggestion that you have to assume that the pancreas is extensively involved. Even in a periampullary carcinoma, which has transmural and pancreatic infiltration, the survival suddenly plummets. And if you are going to do a periadventitial dissection of the superior mesenteric artery, so you are going to do an LV2 at least in all cases. I just want to suggest that to you. That's been our policy for some years now, and we found that the number of local recurrences also dropped, and that's data which is awaiting publication. But it's a real lesson that we learned, and it sort of standardizes the procedure. You are no longer touching. Trying to see whether you are trying to see how much ulcerate process you are taking out. What you are doing is simply dissecting the SMA. Just the Maybury, the Hopsley technique of paroidectomy, that you just do the facial nerve dissection and forget about the parotid comes to mind. So the same way I ask our residents, I ask our trainees to just concentrate on the SMA and take out. And unfortunately, the first part of the jejunum is just a continuum of this. So unless you rotate this and then you take away that tissue as well, the last frontier may not be cleared. So after doing such an extensive operation, we all want to reap the rewards. So my suggestion is be radical if you can.
Thank you so much, sir. That this is actually very valuable.
Yeah, I think in the interest of time, let us move ahead with the discussion, because otherwise it's going to be difficult, to complete this. So maybe I'll straight ahead go to some portion of systemic therapy in pancreatic cancer, and Dr. Soumya, what is your usual regimen of choice? When you want to start these patients, and how do you choose the regimen to be appropriate for each patient?
So Vivek, mostly we go for a modified FOLFIRINOX when we are considering for a neoadjuvant strategy. And
by modified, you mean 150 milligram per meter square of irinotecan and not 180, correct?
Correct. So irinotecan of 150 milligram per meter square and 5-FU infusional. So after that, the toxicity has come down. So that's how modified FOLFIRINOX is easy.
Are you happy to start like full dose for every patient?
So
or you start with a lower dose?
Yeah, until and unless patient is of poor PS, we usually don't compromise the chemotherapy. So if we feel that the patient is not going to tolerate, then we sometimes decrease the dose, but mostly hasn't been a problem. And somebody who is whom we are considering a patient is not fit, then sometimes we give an apaclidine and gemcitabine. So there are trials from the SWOG that show that both are equal also. So
Great.
we try to give a modified FOLFIRINOX.
Yeah. Dr. Vamshi, any differences so far as the chemotherapy regimen, and how many cycles or of neoadjuvant intent in a borderline resectable?
So FOLFIRINOX has better results. Definitely, we would want to give that. We would want to wait for at least 3 to 4 months of treatment before jumping the gun and giving for surgery. Best results are seen after 4 months, 3 to 4 months.
4 months. So are the
four.
surgeons happy with 4 months, or they want
They're okay
just
with
2
that.
months?
No, they're okay with that. They're okay with that. I don't think. See, again, it's not surgeons want, my like. So, like, I don't know I cannot quote you the paper, but there's a paper which showed that at least 4 cycles, 4 months gives you better resection rates than 2 months. I don't remember the paper exactly, but there's a paper on that. So, you know, you have to
Dr.
trust the paper.
Shanaya, what is your institutional protocol, and when do you reassess for surgery? After how many cycles of a FOLFIRINOX or a gemcitabine nab
I
paclitaxel?
definitely agree with Vamshi on this, that you would want to give as much chemotherapy as you can before, because the patients are usually not able to tolerate much after. But we still are on a situation where we cannot say how many cycles is the right number before surgery. As of now, we are pushing for TNT, but we're still not there yet to understand whether 8 is fine, 12 is fine, or you stop at 6 and go ahead with the surgery. But that is something that we try to do, is give as much chemotherapy till the patient can tolerate a major surgery, which is very essential for us to understand during that time phase, that the ECOG has to remain in a good condition. The disease is not going to respond on the scan in 80% of patients on the CT scan, even though your CA19-9 is responding biologically. That is more important than assessing your response on CT scan, which we fail to understand a lot of times, that the CT is going to show.
Yeah. So I think a good take-home message probably here is that if after 4 cycles of FOLFIRINOX, you are having a stable disease, and then there is no need to change the regimen, and probably you go ahead with 4 more cycles of FOLFIRINOX. What do you say, Dr. Vamshi?
Oh, I agree with that. So again, normally if you have a CA19.9 elevated, we use that for follow-up. We don't keep on doing scans intermittently unless we suspect a progression there. So we usually will do this planning after 4 months. That's how we are doing now.
One additional point I wanted to add about CA19-9 is that we generally tend to do it after every 4 cycles, because that's when you assess it. You should ideally do it just before you're giving chemotherapy for each cycle to understand what's the graph like, because most of us don't do that, and you would be giving 3 or 4 cycles of unnecessary chemotherapy, which may probably not work. So that is something which we can probably change.
Great.
Vivek, Dr. Arvind here. I just want to briefly tell that, I think it's the going's great. I think maybe we'll have to wind it up maybe in 10 minutes or so. And I just wanted to remind you also that we have a couple of radiation oncologists that we have invited.
Yes, sir. So I was just coming to the chemoradiation part as well. So
right. So just involve them, because I think they should, just in the interest of time, because otherwise then the time will be lesser for them essentially. Thank you, Vivek.
Great. So cutting short, maybe sort of would bring in radiation oncologists as well as to borderline resectable. Would you want to give chemoradiation to these patients, rather than just chemotherapy? Dr. Shirley?
So we don't have the right randomized evidence for this. I mean, in terms of chemoradiation, we have for resectable, the Priopanc, and then we have the SPAC5, which says that, chemoradiation showed some amount of benefit, but of course a delayed benefit with Priopanc. But against the comparison was not the right one in terms of only gemcitabine vis-a-vis of FOLFIRINOX. And in terms of chemoradiation, SPAC actually did much poorer compared to FOLFIRINOX. So I don't think we are looking at chemoradiation per se, but there's a lot of attractive or very good data which is coming up regarding SBRT in the same scenario for BRPC. Of course, Alliance was a failure, but then Alliance has many issues which have been pointed out many a time, particularly with regard to the dose. And recently, last year, we had the SMART study, which has been shown about 50 gray, 5 fractions, SBRT, and we even have the outcomes, even the surgical outcomes shown from SMART, which is showing very attractive data and doesn't show excessive increase in toxicity, and quite a good proportion of patients are undergoing resection. Radiation, I think, definitely helps. What is a takeaway from PREOPANC possibly is that the R0 resection rates were higher in the BRPC subpopulation, and probably compared to resectable and BRPC, it is the BRPC which derived more benefit when compared to the resectable one. So in terms of particularly about the R0 resection rates, I think radiation would definitely add and give benefit.
Yeah, Dr. Bhushan, anything you want to add, your experience regarding neoadjuvant chemoradiation in borderline resectable or unresectable pancreatic cancers?
Yeah, correct. As Dr. Shirley already mentioned, that whenever possible, as per the data and the trial goes, it is neoadjuvant chemotherapy which generally should be given. And then after neoadjuvant chemotherapy, if the patient becomes operable, yes, patient should undergo surgery. But in spite of a standard neoadjuvant chemotherapy, if still there is a inoperability or still a borderline operability, then probably we can employ concurrent chemoradiation to make it a little more operable.
What would be your chemotherapy partner, and how much dose of radiation, and what would you want to sort of give in such patients?
Right.
Like chemotherapy 4 months given or 3 months given, still suboptimal response, patient has not progressed, localized, and then the MDT decides, let us try radiation.
Correct. So if the neoadjuvant chemo is with capecitabine, then we give radiation with gemcitabine. Or if like what we follow, if pre-op neoadjuvant is with gemcit base, then we use capecitabine as in a concurrent setting. So that's why we generally follow in our setup. And those
so you are comfortable using with capecitabine based radiation?
Yes, we do. Of course, we do not treat pancreas like it's not a huge number in our institute, but we do.
Yeah, Dr. Shravan, so post neoadjuvant, and what are the challenges that you get? Do you get more surgical complication post chemotherapy, and how difficult your surgery or how easy your surgery becomes?
So there's definitely a difference when we operate upfront versus post neoadjuvant. The fear is about radiation hampering planes, but during my time at Tata, I did assist a lot of cases where patients came up post neoadjuvant chemo radiation, and then we saw that there was a significant amount of desmoplasia that was going around, and planes with the vessels were difficult to isolate. But as seen even in the PREOPANC trial, that post-chemo radiation patients, the local control was much better. So the YP-N0 rates were actually very good in post-chemo radiation arm. And the post-op pancreatic fistula rate also dropped. So there is a case for it that the pancreas gets a little hard. So maybe it might actually improve surgery. As far as planes are concerned, yes, there are concerns.
Great. So, there is a lot of trials. Most of them are feasibility studies. This was not completed. This was the one which used multiple, sort of drugs, 4 drugs. And it did show that perioperative arm had better results. And this was the SWOG study that actually compared gemcitabine, nab-paclitaxel, and the modified FOLFIRINOX, and both had equivalent outcomes. So, this was what Shomya was referring to. This is the NEPA-FOX, again, was a feasibility study which showed that, yes, it is feasible with FOLFIRINOX. And again, this study was also a small study, showed that it is feasible. This is the meta-analysis. And what is showed that in neoadjuvant, treatment in borderline resectable, the survival was definitely improved with a hazard of 0.66. And the R0 resection rates improved from 29 to 42, so this was also almost 1.5 times. And this is another, interesting Japanese study that, did neoadjuvant gemcitabine plus S1, as compared to an S1 surgery with adjuvant S1, and then showed improved survival with gemcitabine S1 perioperative. So this is again one of those concepts that this NSCT-RT again we discussed that in borderline resectable probably there is less role to go ahead with upfront NSCT-RT, but yes, in cases which are not responding well to NSCT, suboptimal response, still unresectable, then yes, I agree with both Dr. Bhushan and Shirley that NSCT-RT can be tried. These are the studies, Priopanc, and yes, if you look at a comparison, it is not showing enough results. Alliance was again not really. And this was the the preferred regimen study. We did show that FOLFIRINOX was the winner in the 12-month overall survival as compared to other gem cape or chemoradiation or upfront surgery. And this is the meta-analysis which again tells you that although there was a difference, but R0 resection rates was as high as 83%, resection rates was 67%, and median overall survival was really 22 months, not very bad. Now, if I come to Dr. Vamshi, how do you improve these results, and how do you incorporate newer targeted therapies, NGS, immunotherapy, and all those into practice so that you can improve on these results and have better patient outcomes? Where do you see the role for these modern therapeutics in neoadjuvant treatment in pancreatic cancer?
Very little role, unfortunately. 90% of pancreas are KRAS for which we don't have a target. And though we talk of NGS and keep saying, oh, we have this, we have that, that's in every other cancer. In pancreas, I mean, we do NGS because we have to do it or somebody else will do it. But I can hardly count less than 5% of patients where it actually made a difference. And most of those cases are where there was a MSI high or something like a TMB high where some immuno we used. The chance of actually getting a targetable mutation in pancreas is pretty low. I think it's evolving. So we are going to start a trial in metastatic where MTAP inhibitors are going to be used. We will probably look at NRG1. That's one of the few success stories you have in metastasis. So, these are slow and there, but it'll take time. And as of today, would I jump the gun and say, okay, let me do a NGS and then I will give some great treatment? Honestly, no.
Yeah, Dr. Vamshi, what about matching them for targeted clinical trials and other exploratory treatments? So if the options are there based on NGS, they are able to match them to some targeted therapy. These kind of clinical trials are there. Would you be happy to sort of enroll your patients there, or would you be rather go ahead with your traditional FOLFIRINOX rather than going with these experimental treatments?
So these treatments in India, at least trials in neoadjuvant, I am not aware of. Like I said, in metastatic, we are going to start MTAP. So in metastatic, you have KRAS. In metastatic, you might get some BRCA testing and so on. But neoadjuvant, as of now, I'm not aware of trials in India, at least. Given a choice, why not? I would be happy. These are bad diseases. We are talking of major resections with an overall survival of 25 months. We are talking of big FOLFIRINOX, TNT,
correct.
surgery, and 20-month overall survival medians. These are not great diseases. So yes, we'll be happy to use it. But like I said, let's not get our hopes too high. NGS in pancreas is not a great thing.
Dr. Soumya, what about this approach of doing a BRCA or an HRR and then selecting your patients based on the results for FOLFIRINOX or GEM-NAP-PACLI? So do you advocate such an approach, or would you rather go ahead with GEM-NAP-PACLI or FOLFIRINOX as per the clinical condition of the patient? Dr. Soumya.
Yeah, so far it has not worked, and so still we are relying on chemotherapy. So this time in ASCO 25, the PAXG has come out, the Cassandra trial. In the Cassandra trial, the more of chemotherapy they have given, and the EFS is a bit better compared to only FOLFIRINOX. But for your question, still now it is not there in the neoadjuvant setting.
But you still use that in your metastatic setting?
Yeah, in metastatic setting we use them, but post chemotherapy, but we are not using them in the neoadjuvant.
Great. Yes. Now, suppose this is unresectable, and we did talk about RT. So SBRT in Dr. Bhushan, what would you recommend, like for unresectable cases, even post neoadjuvant? Would you go ahead with what kind of RT for these kind of patients?
After giving neoadjuvant chemotherapy, if there is not a good response, patient is still inoperable, I would decide whether I should go for definitive chemoradiation or SBRT depending upon tumor volume and overall general condition of the patient. Now, if I have a tumor volume which is quite bulky, it is touching or pushing duodenum, then we got nodes also. But at the same time, patient general condition is fair. I would choose definitive chemoradiation over SBRT. Versus I have a small disease without much of a nodes. I would choose SBRT as my treatment.
Great, great. And Dr. Vamshi, what about maintenance chemo or observation? What would you choose in these kind of patients? Suppose SBRT has been given, and now what would you want to do? You'd want to continue some sort of a maintenance systemic therapy, like a palliative intent, or would you wait for progression?
We don't know what
Or
works.
maybe further assessment where surgery might be possible after SBRT. What is your approach?
Oh, our experience with radiation has not been great. We have done in this scenario where it is still inoperable, so just give some consolidation RT. But typically the rest they relapse in 3 to 6 months. Very few patients who actually do a long term. Giving systemic, well, we can give. We don't know if it works. The challenge is if you start doing, from day one you're saying borderline resectable, then you give CTRT saying it's localized, and then you switch gear and say, okay, now I'm going to give you palliative maintenance. So we don't do that normally. We wait till it relapses, but typically the relapse is pretty fast. So if you cannot operate, I mean, a pancreatic tumor, if it cannot operate and on day one, it is LAPC and you cannot operate it, practically, for all practical purpose, it is like a metastatic disease only. The outcomes are not great. But
Dr.
as of now,
Shanaya,
to answer your question, we don't do maintenance.
Yeah, Dr. Shanaya, so in such kind of patients post neoadjuvant and post RT where surgery was not feasible, now is in your experience have some of these patients do landed up in surgery after a few weeks of RT when you have reassessed? What is your opinion?
Yeah, some of them, if you are either considering for a periarterial divestment in which you remove the arterial wall along with the tumor to get a negative margin, because that is your primary aim in resecting a pancreas. Otherwise, there's no point in operating. So either you're planning for that or an arterial resection, you can definitely achieve, but you would want some time to be lapsed after your definitive CTRT or an SBRT, because you basically the whole thought process as to why that has been given has to be understood, and at every time point you have to be in a multidisciplinary team approach with your radiation and your medical oncologist, all three of you with the same sync. That's how it's going to help.
Yeah, most of the times, you have these patients really emaciated and, not really having very good quality of life. And most of the times, even though they might be, sort of operable or resectable, the family itself, they don't want to go for surgery in these kinds of, cases after so many months. Well, surgery done. This is also something that is possible, probably in around 40-50% of cases in borderline resectable pancreatic cancers. So, what about the adjuvant, Dr. Shomya? There are ideally you would want to complete 6 months, but there are also small studies that have indicated that not every patient will benefit from the adjuvant after you have given neoadjuvant, and the benefit may be they're only in some node positive patients, or maybe in patients where you have not had enough CA 19.9 response. So what is your approach to adjuvant? Will you sort of complete what you left incomplete in the neoadjuvant, or would you sometimes select your patients for your adjuvant based on their performance status, post surgical status, duration from the surgery, or the CA 19.9 or nodal status does come in to decide whether you are going to give them adjuvant further or not, and also the response, the TRG response to your new adjuvant.
Yeah, for all practical purposes, if they have been given neoadjuvant, then they are at a very high risk of relapse in future. So probably if I have not completed my 6 months, then I would like to give them. Having said that, post Whipple's, many of the patients are not very fit to continue the FOLFIRINOX. So in that case, either we modify them, or it sometimes is a tough one actually.
Yeah. So if you're not able to give FOLFIRINOX, what do you do in such patients? Like, you leave them, or you still
Yeah,
give them
so
something?
yeah, no, mostly we leave them and again reassess. Maybe still another 2 months. So post people's, it's very tough for them to recover. But once they recover, again we try to complete whatever is left.
Great. Dr. Vamshi, your opinion on adjuvant, like 4 months of neoadjuvant you gave, patient went for surgery, 2 months later, the patient returns post-surgery. How are you approaching the new adjuvant here?
I think Vamshi had to log out, I think, because I
Yeah.
think that maybe the time's also up. Maybe I think
Yeah,
Vivek,
so I
if you
think
could sort of,
we have completed the entire discussion, sir. We have had very good discussion so far as identifying the patients are there. Harmonizing neoadjuvant, selecting proper patients for surgery, and then maybe sort of based on the response, looking at the further treatment. No amount of discussion probably would suffice, because there is a large heterogeneity in what kind of patients we see, and the kind of responses that are there, and biologically it is such a variable disease that we've hardly had enough clinical trials or modern treatments like immunotherapy or targeted therapy benefiting the patients of pancreatic cancer. So with this, I thank all the panelists for a very nice panel discussion, and back to the organizers. Thank you.
yeah. Thank you, Vivek. I think that was really truly a great multidisciplinary panel. Normally, in every pancreas panel, we don't really cover so much in depth about especially SBRT, maintenance, neoadjuvant, novel markers, and so it starts and stops with the surgeon's buck. So I think this time, I think in a truly multidisciplinary sense, you could sort of bring out the best amongst all the panelists and bring out all the major nuances in the management of borderline pancreatic cancers. Thank you for that, and thank you all the panelists for chiming in this. Of course, we must thank also Professor Ramesh and Professor Manish for that excellent debate, and Dr. Shailesh for sort of at a short notice to sort of come and give his expert perspectives while he was on travel. This was truly successful in the sense there was this was conceived in a short notice, and I must thank all the debaters, speakers, panelists for sort of coming on board. We have had almost 275 plus attendees for this particular webinar, which is a sort of a record of sorts. And I must sort of thank everybody for their active participation in this as well. I must also thank, I think, Sabita, Samir, and Sumant. I think the program directors, they've done an excellent job in sort of, getting together all of you all at such a short notice. And sort of, this is something that is sort of, which we didn't really expect, that such great attendance and such vibrant discussions happening. The next ISO virtual webinar would be on the for third week of August 20th. So please sort of stay tuned. We will have more updates about the topic that would be there. Same time, 7:30. And again, I would sort of thank Dr. Tuprani sir for sort of coming. I think he has had some extensive travels from apart from other challenges. So and he's been there for the entire duration. Our president, who keeps motivating us to perform. And I think these ISO webinars, the multidisciplinary webinars, are something that has been really popular because we get to learn from every other domain expert in the field. And I think with that, I would thank you all for joining, and hope to see you in the next 10th edition of the webinar on August 20th. Good night, everybody.
Thank you.
Thank you.
Thank you, sir.